If you said B, elevated AA gradient but normal pulmonary capillary wedge pressure, you are correct. This is what you would expect to see in ARDS, which can be caused by severe pancreatitis. Now we'll move on to acute liver injury and chronic liver disease. Many things can cause acute liver injury. You can pause to review this brief list. The most common will be alcohol, medications, and other ingested substances, as well as infections like viral hepatitis or liver abscesses. Many of the things that cause acute liver injury, like alcohol and the chronic viral hepatitis, can progress to chronic liver disease. While alcoholic liver disease is still the most common cause of chronic liver disease, it's followed closely by metabolic-associated steatotic liver disease, MASLD, or metabolic-associated steatohepatitis, or MASH. Autoimmune hepatitis and inherited metabolic liver diseases like hereditary hemochromatosis can also cause chronic liver disease. We'll talk more about these, as well as primary sclerosing cholangitis and primary biliary cholangitis a bit later on. The viral hepatitis can all cause acute liver injury at the time of infection. However, hepatitis A and E are typically self-limited, though in rare cases they can lead to fulminant hepatitis, particularly with hepatitis E in pregnant patients. Both hepatitis A and E are transmitted via the fecal-oral route, usually through contaminated food or water. Hepatitis E is very rare in the U.S. and is typically seen in northern or sub-Saharan Africa, the Middle East, South Asia, or Central America. There is a vaccine against hepatitis A, but not for hepatitis E. Both can be diagnosed with serum hepatitis A or E specific IgM. Once someone clears the infection, they will typically have a positive IgG for life afterward. For hepatitis A, vaccinated patients will also have a positive serum IgG. Once someone has either been vaccinated against hepatitis A or cleared their infection, they are immune. And the same applies to hepatitis E, once they have cleared their infection. Hepatitis B and C can both cause acute liver injury, even fulminant liver injury, at the time of infection, but are more commonly diagnosed years after initial infection, as the initial infection may only cause flu-like symptoms and nausea, or no symptoms at all. Both are common causes of chronic liver disease and cirrhosis. Both are transmitted through bloodborne transmission, sex, or vertically from mother to child. There is a vaccine against hepatitis B, but not hepatitis C. We'll go into the serologies for hepatitis B on the next slide, but hepatitis C is screened for with hepatitis C viral IgG, and infection is confirmed with serum PCR, which will give you a viral load. About a quarter of people exposed to hepatitis C will clear it on their own, and therefore have a positive hepatitis C antibody, but a negative PCR. Hepatitis C is now curable, and any patient with chronic hepatitis C should be referred for treatment. Hepatitis B, however, is not curable, but some patients may benefit from chronic antiviral treatment to suppress viral replication and prevent further liver inflammation that can lead to steatosis, cirrhosis, or hepatocellular carcinoma. Hepatitis D is unique in that it requires hepatitis B to be present in order to replicate, so patients can't get hepatitis D unless they already have hepatitis B, called superinfection, or if they acquire both at the same time, called co-infection. Hepatitis D is transmitted via blood, sexual contact, or vertically, just like hepatitis B. Hepatitis B and D co-infection or superinfection both increase the risk for fulminant hepatitis and more rapid progression to cirrhosis or hepatocellular carcinoma. It can be diagnosed using IgG, IgM, or PCR. There is no specific treatment, though treating hepatitis B will reduce replication of hepatitis D. The diagnosis of hepatitis B has several steps and can be confusing even for an ID physician such as myself. This is because different antibodies and antigens are detectable in different phases of infection. When a person is first exposed to hepatitis B, viral DNA is detectable first, around 2 weeks after exposure. After this, hepatitis B surface antigen is detectable, about a month after initial infection, followed by hepatitis E or envelope antigen. Symptoms typically occur 2 to 6 months after exposure, and during this period, the surface and envelope antigens typically resolve, and expression of the core, surface, and envelope antibodies begins. Once someone has been exposed to hepatitis B, core antibody, IgG, is typically expressed for life, even if they are part of the 25% of patients that cleared the disease. Patients with cleared hepatitis B will express both core and surface antibody. Patients with chronic hepatitis B will have detectable core antibody and surface antigen. Expression of envelope antigen, envelope antibody, and detectable viremia with Hep B PCR can go through phases of activity for the rest of a person's life. Hepatitis B persists in the hepatocytes and can reactivate and start replicating again at any time. And the combination in which these appear, as well as the ALT level, are used to determine the immune control status of someone with chronic hepatitis B. When a patient has chronic hepatitis B, the labs are checked every 6 months to see if patients meet criteria for treatment. It is also recommended that anyone with chronic hepatitis B have a liver ultrasound done every 6 months to screen for hepatocellular carcinoma, which can develop even in patients who do not yet have cirrhosis. If someone has been vaccinated against hepatitis B, they will only express hepatitis B surface antibody. Different organizations have different recommendations for who should be treated for chronic hepatitis B, and as these can change quickly, you will likely not be tested on this. But all organizations agree that all patients with cirrhosis who have chronic hepatitis B should be treated to prevent disease progression and decrease the risk for the development of hepatocellular carcinoma. Let's try some questions.